talk about errors that we did. So next session will be on errors in dialysis, and there are two parts of it. There are technical errors, there are clinical errors. So to deliver this talk, we have Dr. Ambekar and Dr. Snehal Gaikwad. Dr. Ambekar is well-known nephrologist in Pune and is also honorary professor at Sassoon Hospital. So I'll invite Snehal to start her talk first.
Good morning, everybody. I am pleasantly surprised to see so many people on a Sunday over here. I wonder what everybody's spouse is saying when you're all coming over here. I would like this session to be a little interactive. My request is seniors should not talk. You are included as a senior. So even Kailas is there, and all practicing nephrologists should not talk. This topic is open to students. आणि मी थोडंसं प्रेझेंट पण आणलं आहे. आय विल बी आस्किंग यू क्वेश्चन्स अँड इफ यू गिव्ह द राईट आन्सर आय विल गिव्ह यू अ बाकरवडी. इट्स अ स्मॉल वन, पुणेरी स्टाईल थोडीशी. ससून की आदत है तो फिर माइक करने की ज़रूरत नहीं है, लेकिन ठीक है अगर होगा तो अच्छा है. May I have some volunteer, Vipul?
सर मैं लगाऊं सर?
हाँ लगा.
एक आप ऐसे सर कंफर्टेबल?
या कोण वाटायला आहे का?
ऑन कर दूं? हाँ सर, shall I on?
Yeah, am I audible? Yeah. Okay. So, do we have a changer, sir? Okay. Errors in hemodialysis or dialysis can be human or can be machine related, or there can be manufacturing defects, as you can see over here. So this is what my children call me, manufacturing defect. So we'll go to when you enter into a dialysis unit, the first thing that I like this cartoon very much is this sister is sitting in charge, and as you know, all this discussion was the dialysis technicians and sisters are managing dialysis units. So do you want to speak to the doctor in charge or to the nurse who knows what is going on? Because half the doctors there, when I went for inspections, you won't believe it, but I'll give you my practical experience. When I went for an inspection and I asked the sister, who is this person? He was the nephrologist, and she couldn't recognize him. So I was a little stunned and not prepared for such a thing. But anyway, we'll go to the first. This is my own observation. It may not be correct, but it is my observation that I always say that when you have rigors on dialysis, I think the first thing that you need to see is, has every patient got rigors or is it a single person? Number one. If multiple patients have rigors, look at the water treatment plant. You should, all those students are going to appear for DNB nephrology. Just pray that you don't get Dr. Lobo or Dr. Rajapurkar as your examiners. Otherwise, they are going to ask you about your dialysis, water treatment plant, dialysis machine. So better study and go when you go. So if you have a single patient, then it is probably patient related. Look at whether it is sperm cath or AV fistula, whether the dialyzer tubing is reused or not, timing of a rigor. Whenever the rigors come, is it just after starting dialysis? Is it a formalin or a disinfection reaction? Is it due to improper cleaning? Water treatment rigors would probably, those which are related to water treatment would occur little later, not immediately, and they would occur with many patients. And if my own experience is that if the fever persists beyond 24 hours, admit the patient, because such, I'm talking of maintenance dialysis patients. Okay, there is something like a first use syndrome which you don't see. Type A is where there is a severe anaphylactic reaction, and a type B where the reaction is mild. It's not seen nowadays, so I would really not adhere to it very much. Now we'll go to the first case. I want your inputs. Okay, this is a 61-year-old female who is on hemodialysis twice a week. She came for dialysis. Her blood pressure was 150/90, pulse was 84, and she had her clinical examination was normal. There was her weight gain was 1.4 kg. Okay, she came on to dialysis. Vascular access was perm cath, F6 dialyzer, fragmin was given. Duration was 4 hours. UF was mentioned as 2 liters. Hemodialysis started at 7:50 a.m. Hemodialysis going on uneven till 9:45. And then what happened? Just see. Patient became unresponsive suddenly. Okay. So what happened in this dialysis unit was the radial pulse was absent, carotid was absent, and breathing had stopped. We started CPR immediately, breathing given mouth to mouth. We don't have a fancy dialysis unit like Dr. Lobo or all these hi-fi hospitals. My dialysis unit is a small one. 1000 cc of normal saline was given, and patient became responsive. Blood pressure was 60. Saline again was given 500 ml. Patient complained of difficulty in breathing and chest pain. ECG was done, which was nothing not remarkable. 2D echo was done, and this was her chest X-ray. So now the question is, why did the patient become unresponsive? Okay, any guess? Fast. मी बाकरवडी आणली आहे ना, मी देतो ना तुम्हाला, पण तुम्ही काहीतरी विचारलं पाहिजे. हां, हायपोग्लायसिमिया. ओके, हायपोटेन्शन. ओके, त्यांना एक बाकरवडी द्या, सिस्टरला द्या. गुड, व्हेरी गुड. सो इट वॉज हायपोटेन्शन, बट ॲज यू राईटली सेड, सरांना पण एक बाकरवडी दे रे विपुल, जरा बाकरवडी दे सरांना. त्यांनी हायपोग्लायसिमिया समथिंग दॅट यू शुड चेक, because hypoglycemia is known to occur on hemodialysis. So be careful, that is one learning. So any information you want, fluid removal was only 600 ml as per the machine. So what was the cause of chest pain? Pericardial effusion, pulmonary embolism, air embolism, acute myocardial infarct, any other? It wasn't anything complicated. Tila cardiac massage दिल्यानंतर ते ribs ब्रेक झाले होते म्हणून ते झालं. So she was shifted to a higher center. 2D echo was normal. As I said, CXR showed third costochondral joint subluxation. And we had enthusiastic medical doctors on duty. So activity was immediately started. Okay. So the next patient came for dialysis. 58-year-old male, diabetes, hypertension, CKD, taken up. The weight gain was 2 kg. We started with ultrafiltration of 2 liters. Again had hypotension 1 hour later. BP 80/40, 200 ml NS given, improved to 110/80, and after some time again the BP dropped. Then 300 ml saline given. Now what? Same scenario. Sir, you are a senior person. Let the juniors. Yes. No anti-hypertension. Your point is valid. पण तुला दिलं होतं ना रे बाकरवडी आता? नाही दिली. बरं, एक देऊन टाका त्यांना. So after dialysis, watch what happened. See, UF removal was shown as 500 ml. But the actual weight loss was 4.5 kg. Yes. But you won't get Bakarwadi. I told you don't talk in between. Seniors are not allowed. Machine was same. So don't ever think that dialysis unit is a very nice thing to have and there is no problem. You are going to be faced with problems. Now we'll go to another case. 47-year-old male, diabetes, hypertension, chronic kidney disease, on dialysis thrice a week. Taken up for dialysis, weight gain was about 2 kg. Dialysis started 2.7 liters negative. HD started for 4 hours. Throughout the dialysis, patient had no complaints. Machine had no alarm. At the end of the dialysis, the BP was 180/100. He was complaining of breathlessness. Post weight gain, post weight was 52.5. So gain was 1.5 kg despite putting a negative ultrafiltration volume of 2.7. So what's your take now? Pardon? Okay, good. But सरांना बाकरवाडी मिळेल का? बरं द्या एक बाकरवाडी चला त्यांना. See, what we assume that whatever you put on the machine is going to be is correct. Don't think like that. You keep your eyes and ears open. What had happened is this patient gained 1.5 liters weight on dialysis. So actually then we don't hesitate to redo dialysis again in such a patient. If you are finding that there is a problem, so the UF was actually this time set as 4 liters. As a precautionary measure, dialysis was discontinued in between and weight was checked. Weight had come down. Of course, the machine was changed and dialysis continued for 4 hours. End of dialysis 49.5. So the weight loss was there from 51.5 to another, I think it was 52.5. So it had dropped down to by 3 kg. So what is the problem? Actually, the problem is here. There can be a problem in the ultrafiltration valve. In the first 2 cases, it was due to excessive fluid removal. In the other last case, it was decreased fluid removal. So there is a TMP, transmembrane pressure sensor, and there is an ultrafiltration pump or a valve. So you have to be very careful that these are calibrated many times, and they run a demi dialysis actually, which we never do. I don't know the policy of most of the hospitals, but it's not really done. So be careful. As I said, this is the ultrafiltration valve which you can see. We'll go to the next case. 62-year-old female, diabetes, hypertension, chronic kidney disease. We did her hemodialysis. She went home after dialysis. Next day morning, she became suddenly severely breathless. She had profuse sweating, unable to sit up in bed. She had coughing. Blood pressure was 190/110. She had bilateral, she was coming for regular dialysis. Hemoglobin was 10.4. Platelet count was normal. Urea creatinine was not really raised because she had undergone dialysis earlier. And serum proteins were okay. This was her VBG report, which was done. This was her admission X-ray. Okay, you can make out there is pulmonary edema on this X-ray. She was given NIV support. She was shifted to a hospital near her house, and NIV support, hydrocortisone and Ditor and everything was done. 2D echo was done, which was normal. Ultrasound showed 150 to 200 cc fluid on either side. Patient was admitted in with the above complaints and taken on NIV support, and then she was started on SLED, and SLED was done with an UF of 3 liters. Cardiologist diagnosed hypertensive heart failure and advised target BP of 130/80. Again, patient underwent dialysis the next day. SLED was done for 5 days in a row.
and weight reduction was 6 kg. So tell me what is wrong. Where did I go wrong in this patient? Seniors don't answer. But correct. So what we assume. तुला बाकरवाडी मिळाली का रे? नाही. Please give him a बाकरवाडी. Okay, so you are absolutely right. What we assume, we see the patients in and out, but you should look at the dry weight again of these patients, because times they just come for dialysis and go, and we need to sort of rethink about the dry weight. So you don't, this was the X-ray after the weight was got down. So dry weight overestimation leading to pulmonary edema, because dry weight is not a constant entity. It will change the patient's food intake and lifestyle. It will, if there is an acute illness, it will come down. So my honest advice to you is, if the patient is having an illness, try and get the dry weight down or calibrate it as much as you can, because that is an important thing. And actually, Dr. Lobo himself pointed out this. When did we realize it? Is that when you take up a patient for dialysis and for a transplant, each of our patients has actually lost weight, nearly to the extent of 6 kg once the kidney starts working. So this was all fluid, which you won't believe it, I made the mistake, and the mistake was in a doctor who was on dialysis with me. He also lost 6 kg on after the kidney started working. So I was really surprised, and so was he. He said, "Wazan evda khali ka gela hai?" So that was the real answer. So each of your patients will have volume excess. Only thing is how to diagnose it. Should I shut down?
I'll just add to that. We did bioimpedance for patients who are going for transplants and measured their weight, which we consider as dry weight, at the 1 month of transplant, and there was at least loss of 2 kg, on an average loss of about 3 kg post transplant.
Right. Fresenius has a machine which they use for fluid estimation. So I guess if you can afford it, I can't. मी जरा गरीब डॉक्टर आहे त्यामुळे, पण ज्यांना परवडतंय त्यांनी घ्यावं.
It's not really worth spending that money.
Okay. So you don't need to diagnose fluid overload like this, and remember adequate dialysis. So if you are, you can see this cartoon. This nurse is telling Santa Claus, I don't care what day it is, 4 hours is 4 hours. Should I shut up?
Yes, sir, we can switch over to.
Right, okay. I'll just conclude one thing. Just give me 2 minutes, okay?
Yes, sir.
70-year-old male, missed dialysis, developed fracture neck fever, urea 180, creatinine 9. Patient, he was taken for dialysis in a new ICU, okay? 3 dialysis done. At the end of 3rd dialysis, patient became drowsy and disoriented. Possible diagnosis? Fat embolism, okay. Who said that? You can give them a bakarwadi, okay. That is possible. This was the electrolytes. Actually, I gave a hint. It was in the new ICU. And Dr. Sunil Zavade deserves that credit, because he was the man, he was the person who pointed out that this, see urea, creatinine, and see the calcium. Any new place where you are starting dialysis, look at the RO system. The RO system was not connected and the calcium was high, and this new ICU, somebody dumped bore water into that corporation tank, and when you mix up bore and corporation, this is what you get most of the time. So another just point of entry is, as Dr. Lobo said, there is a device on the machine which will tell you when the disinfection has been done. So be sure at least once in a month look at this the part on the machine. It will give you some idea when the last disinfection is done. And you can see the cleaning process also on the machine. So my last slide, lessons to be learned. If you cannot solve a problem, what you will do? Bakarwadi shillak ahe ka? Aye. So you answer this question fast. This is important. If you cannot solve a problem, what will you do? Right. So first, you received a Bakarwadi? No. Then he gets one Bakarwadi. You are absolutely right. Dr. Georgie Abraham, senior nephrologist, has mentioned this. Okay. If there is a problem on dialysis which cannot be sorted out, what will you do? Fast. Something you would not like to do, but you will do. Pardon? Dialysis. Correct. Stop dialysis. This was told to be my dialysis technician, Mr. Shinde from Sassoon Hospital. Okay. And if there is a problem in dialysis, who is to blame? Nephrologist. Who said that? Sir. Good. This was pointed out by Dr. Lobo. Sir, Bakarwadi, I'll give it to you later on. Okay. And A.J. Cronin mentioned, Dr. Wadia will know, he was a physician and he's written books, and the book is The Citadel. And if you have read that book, he was asked a last question in MRCP exam, what have you learnt in medicine? And guess what his answer was? His answer was, don't take anything for granted. So ladies and gentlemen, don't take anything for granted. Amir Sohail, since it is cricket match season, Amir Sohail ni Venkatesh Prasadla सांगितलं होतं मी तुझी पुढचा ball boundary la मारणार आहे, and this was the result after that. His wicket was lost, and I think Wasim Akram was very angry with him for the same. So ladies and gentlemen, this is my final slide. Dr. Rajapurkar, B.V. Gandhi sir, Ukidwe sir, and Shashikant Gajre, all my teachers from KEM, all are here, and Dr. Wadia, but I don't have his photo in this slide. Thank you so much.
Because the session was divided, I'll call Snehal Gaikwad to clear her part of talk, and then we can take questions.
I'm afraid after such a good session, mine is going to be a little boring. As Vipul says, I put a lot of stuff on the slide. It's more so for the students to have a ready reckoner. You know? Okay. So, pardon me beforehand. So, case 1. A 60-year-old male on maintenance hemodialysis, diabetic, hypertensive, ischemic heart disease post-PTCA, and had a standard hemodialysis prescription of blood flow, dialysate flow, bicarb-based dialysis, dialysing through a fistula, but initial vitals and all were stable. Towards the end of second hour, develops an altered sensorium, sudden onset altered sensorium, confusion and hypotension, with the blood pressure dropping to 104 and saturating at 91, 92, deep drowsy on examination with extensor plantar. So what do you think is happening here? What seems to be the likely cause or the likely causes which comes to your mind? This is a regular maintenance hemodialysis patient who has been dialysing for quite some time. So yes, it could still be a dialysis disequilibrium. Next. Sorry, IC bleed, yes. There are no wrong answers here. Yes.
Yeah,
it could be hypoglycemia, it could be an electrolyte disequilibrium. It could be a dialysis disequilibrium, metabolic encephalopathy, cerebrovascular accident, or hematomas, hypertension trigger, associated press, or a non-convulsive status epilepticus. Infection should be ruled out in each, but seems less likely here. So when the parameters were analyzed, patient see the electrolytes of the patient. Sodium had dropped to 120, potassium 4.6, chloride 98. Rest of the parameters were unremarkable. CRP was negative, ammonia was normal. So what seems to be the cause here? I don't know. Acha. Laser pointer. Thank you. So the sodium has dropped to 120. What seems to be the likely cause here? Yes. It is, we'll come to it, yes, conductivity failure. So what was done immediately was that dialysis was terminated and clinically diagnosed as acute cerebral edema, secondary to hyponatremia. So the cause here was rightly pointed out by him, proportioning pump failure malfunction with failure to of the conductivity alarm to be triggered. So the theoretical component here, theoretical discussion is about the typical components in the dialysis circuit, but I'm being told it was already covered. So I'll just briefly talk that in a typical dialysis circuit, there is the inlet water, which is then heated to around 35. Then it was passed through the deaeration chamber. Then there's a proportioning system, wherein first the bicarbonate B part of the concentrate is taken, then the A part, these are mixed together with the RO water and then passed through a conductivity monitor. And if the conductivity is not appropriate, that's usually 12.5 to 15, ideally between the tight range of 13 to 14, then if it is not achieved while on the dialysis, the machine doesn't allow it to be infused, further infused into the circuit, and it will be passed through a bypass valve. So in various machines have different mixing ratios, which should be kept in mind. The standard Fresenius ones will take in 1 part of acid, 1.225 part of the bicarbonate, and then 32.77 parts of water to form the final dialysate. Likewise, Requiloc will have 36.83 and Cobe machines have 45x. All this, for the want of time, I won't be talking much in detail about the conductivity meter. Please go through the slides at a later date. What is conductivity is the measurement of the ability of the total ionic content of the dialysate to conduct the electricity. So electrolytes, as we all know, break down into the ions in an aqueous solution, and this is then measured by the electrodes to give the final reading to us. This is how the front display panel looks like on the Fresenius 4008 machine, wherein there is a separate conductivity meter displayed, and this is how it is measured. I'll be skipping this. Please read through. It's a little interesting. When you know the basics of it, you'll remember it more better. So the range usually set, the machine allows is between 12.5 to 16, but it should be in a tighter range between 13 to 15.5 millisieverts in per centimeter. So what has happened in our patient was there was a proportioning pump malfunction. What are the likely causes are that it could be that the pump has wear due to the continuous use there is a wear and tear or leakage, or there is a blockage. Then there are the lines may be kinked, or there may be an error in the proportioning system when the concentrate was changed. There may be a sensor failure, or a wrong concentrate was used, or mismatch ratios. So clinically, it will manifest as a it may show low conductivity. If there is a defect in the conductivity alarm, then no alarm may be triggered, and the dialysate pH may vary. The patient may develop cramps, hypertension, and arrhythmias or altered sensorium. So in such cases, what is to be done is immediately, when in doubt, stop the dialysis. Okay. So switch. Then verify the conductivity manually, inspect the concentrate containers, confirm that the B part is on the B part, the bicarbonate is placed on the B part, the acid concentrate is placed on the A part, check for any air bubbles seen, examine the proportioning pumps, and if alarm failure is detected, document it, and do not use the machine until it has been thoroughly checked by the engineer. So complete calibration and preventive maintenance must be done. Also, on the patient part, after the verification has been done, still run the machine through the test mode and externally check the conductivity, confirm the pH range. So always remember, Machine monitors are either mechanically or electrically operated and are prone to failure. There's a Murphy's law. If anything can go wrong, it will go wrong. So always keep this in mind, and it should be accepted as a fact. And nothing can override a manual inspection by the hemodialysis personnel. So coming to the case 2, this is a 40-year-old female who was diabetic, hypertensive, and DKD stage 3. For some acute reason, developed an AKI, KDIGO stage 3, requiring dialysis, that's urosepsis, and was dialyzing through a temp line and right IJV. She developed sudden onset dyspnea during a session of hemodialysis. There's no preceding history or accompanying history of chest pain, pedal edema, orthopnea, no hypertension, no syncope, no blood loss on dialysis, no fever for that matter. On examination, she was found to be tachypneic, was pale, had 1+ edema. The blood pressure was 180/110. She was saturating 60% on 10 liters of O2. There were bilateral basal crepes, no gallop, and was completely, CNS was unremarkable. So what was done was that the dialysis was temporarily stopped. Patient was shifted to a CCU for monitoring and put on NIV. X-ray chest did show pulmonary edema, and 2D echo show moderate LV function of 50%. So considering volume overload pulmonary edema, the dialysis was restarted. Patient improved with the ultrafiltration of 2 kilos, and the subsequent USG did show that there were no B lines. But still, despite this, the saturation of the patient only improved from 60% to 72%. So labs done showed that patient had severe anemia, had developed severe anemia with a HbA of 5.4. There was normocytic normochromic picture, but just note the LFT. There was rise in the indirect bilirubin of 2.6 and the LDH of 1139. So the ABG was done. Here you can note the in the ABG was done, methemoglobin percentage had increased. So normally it is 0.5 to 1 or less, but here the patient had methemoglobinemia with a 7.1 gram per deciliter. Hypoxia on pulse oximetry with a normal SaO2 and PO2 in ABG suggests presence of an abnormal hemoglobin, which is confirmed raised methemoglobin levels. But in our patient, along with the methemoglobin levels raised, patient also had developed hemolysis. We noted that there was a drop in hemoglobin, and also LDH was raised, there was indirect hemoglobinemia. So what exactly happened in a case, we need to see. For the management part, it remains standard that we need to give a packed red cell transfusion, and methylene blue, that's 1 milligram per kg, was given stat, post which the ABG improved and the methemoglobin levels dropped to 1% from 7.1%. So SpO2 also normalized. But still the answer that why did this develop was to be seen. The treatment charts were reviewed, and the patient was on oral hypertensives, cilnidipine, clonidine, erythropoietin was being given for the anemia, and was on hemodialysis at present for the urosepsis associated AKI. No drugs were implicated, so a possibility of acute hemolysis during dialysis was suspected. So one by one, all the parameters from the circuit to the patient connection were evaluated. The tubings were okay. The dialyses were reprocessed with renaline. Venous pressures were normal. Arterial pressure was not too negative. There was no conductivity or a temperature alarm. So what could have happened is contamination on the the dialysis could be contaminated. So also it was seen that the chlorine meter, the chlorine meter showed normal chlorine levels. The water conductivity was normal, and no other patient in the unit had developed similar events. So the possibility of dialysate contamination at the machine level was suspected. When we went back to the records, it was seen that history of disinfection of the machine done with bleach preceding to this dialysis, this event, and she was the first patient to be taken. So possibility of the residual bleach in the machine was suspected, but subsequent when the checks were done, because the machine had already been rinsed, the chlorine levels came to be normal. So, and the next patient did not have such an event, thereby retrospectively confirming our diagnosis that the residual bleach must have caused by hemolysis and methemoglobinemia. So a word about methemoglobinemia. It's a condition wherein the hemoglobin in
Just
the
a minute, because there was, till that time you can drink water. So there was reason for suspicion of that particular machine because patient was next dialyzed in CCU and she got better with that. So she did not have any problems. It was not the problem with the patient. It was problem with the machine.
Yes.
So that machine was the culprit. We couldn't get the samples because of immediate rinsing that was done.
So as previously Ambekar sir said, look at the cause, whether it's a single patient or the multiple patient, and there are there events on the same machine, subsequent events on the same machine. So here it was the single event associated with the bleach disinfection. So word about methemoglobinemia. In the hemoglobin, when the ferrous ion is oxidized to the ferric state, it develops methemoglobin. Normally the level is 0.4 to 1.5. But when the levels are raised, it develops a clinical syndrome of methemoglobinea. What happens is that the methemoglobin is not able to bind to the oxygen well and also displaces the oxygen dissociation curve, thereby causing a reduction in the total oxygen carrying capacity of the blood. So what in dialysis patient, what are the causes is most common is the residual chloramine or the chlorine is the main cause. So in the water treatment system, the carbon adsorption filters are required to clear out the chlorine and the chloramines and the other pesticides. Therefore, the allowable chlorine levels are less than 0.5 parts per million and the chloramine is less than 0.1 parts per million. The American Standards of Medical Instrumentation recommends that at least 2 carbon beds should be installed in series configuration with the use of medical GAC, that's a granular activated carbon should be used with a minimum iodide number of at least 900 to optimize the chloramine and the chloramine removal. But as initially Rajapurkar sir had said, it depends on the source water. Your requirement, the requirement for this carbon beds depend on your source water. So keep that in mind. How does it present clinically? The patient will develop dyspnea with hypoxia on the pulse oximetry because the SpO2 will drop by 0.5% for every 1% rise in methemoglobin. A patient may develop cyanosis, which in our case did not manifest because the patient was already anemic to begin with. So the anemia masked the cyanosis. Patient may develop neurological symptoms depending on the extent of the methemoglobinemia, and there will be certain extent respiratory depression. So for diagnosis, what we need is an ABG, which measures the presence of abnormal hemoglobin and helps in differentiating with oxy and methoxy, and co-oximetry if available, and direct assays are also available for confirmation of this. In management, we should, when to suspect this, when there is hypoxia, which is not improving by increasing the supplemental oxygen, and there is no hypoxemia on the ABG. Evaluate treatment history to stop all possible drugs which are going on, and supportive care in form of the Taxol transfusions, hydration, ventilation should be done. With therapy with methylene blue should be instituted as early as possible. Some certain extent ascorbic acid also helps, and exchange transfusion or and whenever available and needed, hyperbaric oxygen therapy will help. Thank you.
Is there any comments, questions regarding these 4 errors that we found during dialysis? So that mate HB was quite like it happened somewhere at 10 p.m. and we had to manage overnight. So, but somehow the patient improved well after the second dialysis. So always look for what is wrong with the machine. What airline industry does is any error, any potential error must be identified and rectified. If it is not identified, then we will have many more Air India crashes in Ahmedabad.
Yeah, and unfortunately, as happened with you all, proving something is very difficult, because by the time the water treatment specialists come into the picture or something happens, all the evidence is gone for a toss. So it's very difficult to find out what exactly happened. But circumstantial evidence, I think, points out to that whatever has happened is just be careful when this, think about it, what I mean to say.
So dialysis is life-saving as well as life-threatening therapy. So unless it is well monitored.
What is not?
Yes, sir. May I request Dr. Wadia to give token of appreciation to Dr. Ambekar and Dr. Snehal Gaikwad. Snehal.